Hello, it's Dmitry again. Today we'll be going back to the Mehlman Medical textbook for well, I should say PDF, but you get what I'm saying. The Mehlman Medical PDF for internal medicine. Now we're looking at the Heme chapter. That's Hematology and Oncology chapter. This is going to be about 30 pages or so, and so this might be 2 or 3 videos in total. So this will be like the part 1 essentially. So let's begin. Iron deficiency anemia versus thalassemia. So we have 3 different things: variable, IDA, thalassemia. So iron deficiency anemia. So let's talk about it and how you hold points along with that. So we have the I think that's, what is that? Hemoglobin, right? They're both decreased. Okay. The MCV is decreased for both. Serum MCV is decreased for both. Serum iron is decreased for obviously iron deficiency anemia. However, it's going to be normal in thalassemia. Okay. What about ferritin? Well, it's going to be low in iron deficiency anemia, but it's going to be normal again in thalassemia. What about hemoglobin electrophoresis? Well, in that case, it's going to be normal for iron deficiency anemia, but it's going to be, the alpha will be normal for thalassemia, yes, but the beta will be elevated HbA2 plus HbF. See discussion at bottom of table. Yeah, basically because thalassemia is an issue with the actual structure of the hemoglobin, where there's something wrong. In this case, they're talking about the beta subunits are messed up. And so you have this elevated HbA2 and HbF that's elevated because the normal HbA is like deformed, essentially. It's not the way it should be. And so you can see sort of this holdover of HbF for longer than it should be. And I'm not so sure about HbA2, if that's just like a normal variation. I think it is. But we'll talk more about it at the bottom of the table. Anyway, what happens if we give iron to the patient? Well, if you have IDA, if iron deficiency anemia, well then you're gonna have improvement because you were deficient in iron. But what about with thalassemia? It doesn't really improve anything because, well, it's not an iron deficiency. It's thalassemia. So what are the high yield points? We want to know about this stuff. So far, thalassemia means abnormal synthesis of either the alpha or beta globin chain. It presents 2 ways on USMLE. 1, as a microcytic anemia despite normal iron plus ferritin, or 2, as a patient who has a microcytic anemia despite iron supplementation. Most iron deficiency anemia is seen in menstruating women, even if their menses are not heavy. 2CK will actually explicitly say menses are normal or not heavy, but the diagnosis is still iron deficiency anemia. They kind of throw you off with that comment, you know. NBME will give you a microcytic anemia in a woman who is 32, and the answer is just check serum iron and ferritin. This is because the thalassemia is often misdiagnosed as iron deficiency anemia, where if we get the iron studies back and see iron plus ferritin are normal, we say, oh, okay, that's thalassemia, not IDA. Well, next best step should be hemoglobin electrophoresis. 2CK forms like to give the pregnant woman a first antenatal screening with microcytic anemia who are given iron for 3 weeks but shows no improvement. Question won't mention anything about a patient's iron or ferritin levels, so you say, oh, okay, this is a microcytic anemia despite iron supplementation, meaning the iron plus ferritin are actually normal, so this is thalassemia. Next best step would be hemoglobin electrophoresis. So what about, we'll continue. Again, this column here is IDA, and the other column to the right of that is thalassemia. So RDW, that's the, I believe that's something like the red blood cell distribution width. Yeah, something like the red cell distribution width. Now, along with that, I want to say is that that's talking about like the variability, I believe. Okay, something like that, I believe. But it's elevated in iron deficiency anemia, and it's normal or lower with thalassemia. So let's talk about it. What about red cell distribution width? It says all you need to know is basically always elevated RDW means iron deficiency anemia, straight up 9 out of 10 questions. So if you see that, start thinking about iron deficiency anemia because it's probably what that is. The only question where the RDW is elevated is seen in thalassemia is on CMS-FM form 4, where the IDA is wrong, but they give ferritin within normal range, so IDA is not possible. But the elevated RDW is essentially an erratum as this is rare as heck. Therefore, we can essentially say that elevated RDW is sensitive but not specific to for IDA, where if RDW isn't elevated, we can rule out IDA, but be careful about automatically saying must be IDA if the RDW is elevated, because it doesn't necessarily mean that. Because it's possible that it's not, although even though it's probably pretty likely to be the answer. Blood smear. Blood smear, well, in IDA, it's going to have pale RBCs, which makes sense because you have iron deficiency. But in thalassemia, you have target cells. IDA causes pale RBCs, that is to say, elevated central pallor, not dramatic. Target cells are highly buzzy for pass level for thalassemia, probably 14 out of 15 questions on USMLE mentioning target cells or thalassemia, alpha or beta. So this is another picture right here. It says there is one NBME question that with target cells. So this is the target cells right there. So before we had those hypochromic cells from IDA. The ones down here, those are the actual target cells that we have for thalassemia. There is one NBME question which target cells is in a splenectomy patient, but they're a background finding that don't facilitate the answering the question in any way. What about the treatment? How do you treat iron deficiency anemia? Well, with iron. How do you treat thalassemia? Well, you do transfusions if severe. Oral iron is ideal over paracental IV or intramuscular iron always. I mention this because answers such as parenteral iron are wrong / distractors basically always. Oral iron. I'll say to a student, you want to give the patient IV iron? Oral iron, yeah, question mark, right? Oral iron can cause constipation and black stools. USMLE wants you to know iron, aluminum, antacid, and verapamil milk all cause constipation. Transfusional siderosis, secondary hemochromatosis, is a sophisticated way of saying iron overload due to repeated blood transfusions, that is to say beta thalassemia major. Each RBC transfusion contains iron. Use chelators like deferoxamine to treat. Thalassemia is impaired synthesis of either the alpha or beta globin chain in hemoglobin. The alpha thalassemia can have 1 to 4 alleles mutated. Beta has 2. Don't worry about obscure intermediate types, etc. USMLE overwhelmingly focuses on adults for both alpha and beta thalassemia. Since these patients are usually misdiagnosed as having iron deficiency anemia, that is why you need to know about thalassemia so you don't misdiagnose patients with IDA. Adults with alpha thalassemia will be asymptomatic, 1 mutation, where they have an incidental microcytic anemia picked up on antenatal screening. Adults with 2 mutations have symptoms akin to IDA, but they'll fail to improve with iron supplementation. 3 alpha mutations, HBH disease, beta 4 tetramer, will present as a sick kid. 4 alpha mutations, hemoglobin Bart's, gamma 4 tetramer, will be fatal in utero. Beta thalassemia minor will be 1 mutation in adults who present similar to 2 alpha thalassemia mutations, that is to say similar to IDA, iron deficiency anemia. Beta thalassemia major is 2 mutations and will present as a sick kid similar to 3 alpha thalassemia mutations. Is exceedingly high yield. You know that the beta thalassemia has an elevated HbA2, alpha 2 delta 2, and HbF alpha 2 gamma 2. Alpha thalassemia, 1 or 2 mutations, has normal hemoglobin electrophoresis. Okay. Sick children with thalassemia are known to get chipmunk facies skull, and hepatosplenomegaly occur due to a significant increase in extramedullary hemoptysis. Now, okay. So that's the skull. Chipmunk facies / skull. Anemia of chronic disease, AOCD. The answer on USMLE for anemia with a decrease in hemoglobin in a patient who has a renal failure, an autoimmune disease, that is to say rheumatoid arthritis, JRA. Sorry, what is JRA? JRA disease, juvenile rheumatoid arthritis? Maybe. Rheumatoid arthritis, juvenile rheumatoid arthritis, IBD, so that's irritable bowel syndrome, systemic lupus, erythematous, like lupus basically, etc., hepatitis B, C, HIV, or malignancy. Yeah, okay. Patients will have low iron but normal ferritin, or sometimes slightly high. Ferritin is the most sensitive marker of iron stores, which means these patients are not iron deficient. There's two main reasons for iron is low in AOCD. One, RBC production is decreased because cytokines, namely IL-6 and TNF-alpha, block iron release from the storage sites. And two, hepcidin, a molecule produced by the liver, decreases gut absorption of iron and promotes its storage in cells instead. It is to my observation that renal failure is the highest yield cause of AOCD on USMLE. This is due to the cytokine-mediated EPO deficiency. This is an answer on an NBME form. EPO is a treatment of AOCD only if renal failure is the etiology. Otherwise, the treatment is merely addressing the underlying condition, that is to say the rheumatoid arthritis, and EPO is a wrong answer. There is an AOCD NBME question for rheumatoid arthritis where they say how to treat the answer and is no specific measures indicated. Students say, wait, I thought we were supposed to address the underlying conditions, so I was confused by this answer choice. I agree, so don't take it up with me. Take it up with NBME. One of the highest yield points I can communicate is that even though classic MCV is normal in AOCD, it will be decreased in about 50% of NBME questions. I've seen students say, oh, it can't be AOCD because MCV is low. No, USMLE loves giving you low MCV in AOCD, especially on 2CK forms. I've seen MCVs of 72 and 75 in juvenile rheumatoid arthritis questions. So they're not playing around necessarily. They are gonna, hardball you sometimes, What about multiple myeloma? Cancer of plasma cells. Plasma cells normally secrete immunoglobulins, so we have a significantly elevated serum immunoglobulins. Multiple myeloma is buzzy presentation in the patient over 50 with mid-back pain plus hypercalcemia. Elevated serum calcium occurs due to lytic lesions of bone caused by the proliferating plasma cells. This can present as pathologic rib fractures or pepper pot skull. There is an NBME question floating around. They give lytic lesions of the humerus as well, not buzzy. Textbook is in comparison to rib fracture lesions, but they show you the image is similar to the following. Okay, is this the same thing? Is it multiple myeloma? I don't know. I think so. I think this is multiple myeloma continued. So multiple myeloma continued, I guess. First step in diagnosis is serum protein electrophoresis, SPEP, which shows a significant elevation in serum IgG kappa or lambda light chains. This is known as the M spike, monoclonal spike. This does not mean IgM. Then bone marrow biopsy confirms the diagnosis, showing a greater than 10% plasma cells. A smear in multiple myeloma will show plasma cells, blue cells below, with clock phase chromatin, which is the appearance ascribed to the nuclei, purple below. Your analysis shows Bence-Jones proteinuria, which is simply the IgG light chains in the urine. Amyloidosis is proteins depositing where they should not be depositing. Immunoglobulins are proteins since they are flying around in the blood. They deposit the heart, cardiac amyloidosis, S4 heart sound with diastolic dysfunction, and kidney, renal amyloidosis, nephrotic syndrome. The IgG light chains stick to the RBCs, causing RBCs to stick to each other as stacks, rouleau. These are heavy and sediment quickly on centrifugation, hence the increased or elevated ESR. USMLE can show you a picture of the rouleau rather than the clock phase chromatin, where you need to know instantly the diagnosis is multiple myeloma. So here's a picture here and here, right? Those the little arrows that they're pointing to. Honestly, I can't totally make heads or tails of that as it stands right now. MCV can sometimes be elevated in multiple myeloma. That is to say, 108. Normal range should be 180 to 100. Don't be confused by this. It is common. This is caused by 1, elevated immunoglobulins being transported by RBCs, thereby elevating the RBC size. 2. A decrease in RBC production within bone marrow due to the infiltrating plasma cells, causing an elevation in RBC size to compensate. And 3. B9 and B12 deficiencies can caused by multiple myeloma, i.e. why they're going to have a potentially macrocytic presenting anemia. Well, macrocytic presentation, I should say, just in this particular whatever. Well, the MCV would be high because B9 and B12 can induce a macrocytic anemia. If they're deficient, I should say. Deficiencies of those two can cause a macrocytic anemia. Treatment is initially a IV bisphosphonate to decrease the risk of bone lysis. It should be noted that the patients with bone marrow biopsy shows a decrease in 10% plasma cells have a condition known as MGUS, monoclonal gammopathy of undetermined significance. That makes more sense. There's a small annual risk of progression to multiple myeloma. These patients might have a fatigue and/or an elevated MCV, but no hypercalcemia or renal dysfunction. So where are we now? Are we 15 in? Yeah, we're 16 minutes and some seconds. Okay. So I'll take a break here and come back. Just skip ahead if you're watching a recording. Okay, let's see. Let us continue. So, Waldenstrom macroglobulinemia, cancer of plasmacytoid cells. Oid means like, but it's not. So these are cells that look like plasma cells, but they are not plasma cells. Causes IgM M protein spike on SPEP. multiple myeloma is IgG M protein spike. In contrast to multiple myeloma, does not cause hypercalcemia, lytic lesions, Bence-Jones proteinuria, or amyloidosis. Waldenstrom causes hyperviscosity syndrome, which will present as a headache, blurry vision, tinnitus, or Raynaud phenomenon. Polycythemia vera versus secondary polycythemia. So for polycythemia vera, JAK2 mutation causing proliferation of hemopoietic stem cells. Answer on MBME. Questions will give an elevation in hemoglobin at 18 plus, normal range should be 12 to 17.5, and an elevation of white blood cells and or platelets. In other words, at least 2 of 3 cell lines will be elevated, with RBCs always being elevated. Hemoglobin being elevated can cause hyperviscosity syndrome. Basophilia can cause pruritus after a shower. Erythropoietin is suppressed due to the elevation in hemoglobin. USMLE wants phlebotomy as the answer to decrease the acute symptoms associated with the hyperviscosity syndrome. That is to say, what is the next best step to decrease the patient's headache / blurry vision? Serial phlebotomy and hydroxyurea can be answers to decrease the recurrent symptoms. The USMLE will not give both at the same time. What about secondary polycythemia? Isolated increase in RBCs due to the elevated EPO, that is to say, white blood cells and platelets are normal, seen in those with lung diseases where the arterial O2 tension is low. Kidneys sense the decrease in O2 and secrete EPO, acts on the bone marrow to stimulate erythroid precursors, also seen in the renal cell carcinoma, which can secrete EPO, and parathyroid hormone replacement related protein or peptide, but parathyroid hormone related protein causing hypercalcemia, exogenous administration, that is to say, cyclists. Okay, so it's here brief clotting factor pathway. So this is the extrinsic and the intrinsic pathway. So the intrinsic pathway, 12 to 12. This is a very simplified one. You can go look it up more for information for different stuff. So intrinsic pathway, 12 to 12A, allows 12 to 12A. 12A helps convert pre-kallikrein to kallikrein. 11 to 11A, which is going to help be assisted by 12A. And then 11A will assist 9 to 9A, and that becomes part of the common pathway. Now, there's another pathway called the extrinsic pathway, which is shorter, less complicated, and it's going to be basically tissue factor or factor 3 helps convert 7 to 7A, and then 7A helps convert 9A to, depending on the situation, either it's going to be 9A helps convert 10 to 10A, and it's going to be assisted by, I guess, and they're showing 7A, or you're going to have something like 8A be involved to help convert the 10 to 10A. But I guess in this diagram, they're implying that this one's a little bit more confusing. Let me go look up a different one. So what is this called? The clotting cascade? I think that's not, well, here we go. So the common part, the part of the common pathway, you don't see it here, but I can see it, is 9A helps convert prothrombin to thrombin, which is 10. So 10, which is called prothrombin, is converted into 10A via 2 different methods. One, the intrinsic pathway, which converts it via 9A, converts it via 10A. And then is that right? Okay, so let me read this out. Okay, so 12 becomes 12A by a contact activator. The 12A helps convert 11 to 11A. The 11A helps convert 9 to 9A. And the 9A helps convert 10 to 10A. The 10A converts prothrombin to thrombin. So that's how the intrinsic pathway merges with the common pathway. Now, factor 7 via tissue factor converts into factor 7A, which is the activated factor. Then 7A helps convert 10 to 10A, and then 10A, again, we said before, helps convert 2 to 2A, which is prothrombin to thrombin. So both of them convert factor 10 into factor 10a. So basically in the case of intrinsic, 9a converts 10 to 10a, and in the extrinsic, 7a converts 10 to 10a, and the 10a helps convert 2 to 2a. So that's a little bit more understandable to me. This is a little bit more convoluted, or a little bit more confusing, I should say, because they're implying that somehow 7a interacts with 9a when it really doesn't. So anyway, what else do they have in here? Protein C and protein S mess with 5a, and mess with 5 and factors 5 and factors 8, I guess. Factor C messes with those, that's true. Protein C, protein S is sort of this anticoagulation system of factors. And they, like 2, 7, 9, and 10, they actually do require vitamin K to work and be activated. So that's a context of something you should be aware of in the context of warfarin. So prothrombin time PT reflects the functioning of the extrinsic pathway. Activated partial thromboplastin time PTT, APTT, reflects the intrinsic pathway. So that's intrinsic right there. Again, if I were you, I would look it up on a different diagram online. In other words, if PT alone is high, then the extrinsic pathway is messed up. If PTT alone is high, then the intrinsic pathway has a problem. If both PT and PT are elevated, then the common pathway probably has an issue. Normal PT is 10 to 15 seconds. Normal PTT is 25 to 40 seconds. Normal bleeding time is 2 to 7 minutes. Bleeding time relates to the platelets and has nothing to do with clotting factors. PT and PTT relate to clotting factors and have nothing to do with platelets. Let's continue. High-yield core differential diagnosis for internal medicine. So we have ITP, which is idiopathic. It says here idiopathic/immune thrombocytic purpura. Antibodies against glycoproteins 2b and 3a and platelets. Causes a decrease in low platelets, an elevation in bleeding time, no changes in PT and PTT. Bleeding time is high because the platelets are messed up. PT and PTT are normal because these refer to clotting factors, which has nothing to do with the ITP, the idiopathic/immune thrombocytic purpura. Normal platelet count is 150 to 450,000 microliters. Platelets in the idiopathic/immune thrombocytic purpura, or ITP, questions are usually less than 100,000. Precipitated by viral infection, where the antibodies against viral proteins cross-react with the platelets, disrupts the platelet aggregation, type 2 hypersensitivity. Viral infection will be asymptomatic in 50% of vignettes. In other words, the question need not mention the actual viral infection, so don't get confused if you don't see it. We'll present two ways on USMLE. One, school-age kid, i.e. 12 years old, who has coryza for a few days, followed by petechiae and or nosebleeds. Two, woman who's in her 30s or 40s has no mention of viral infection, plus random bruising and bleeding bruising and bleeding time for 9 minutes. For the latter vignette, if they say exact same question but bleeding time 6 minutes normal, then the answer is domestic abuse, not ITP. There is an unusual 2CK NBME on new NBME where they say the girl has had heavy menses, classically a clotting factor presentation for von Willebrand disease, and the answer is ITP, but von Willebrand disease isn't listed, and the answer choices are clearly wrong, just letting you know this exists. Treatment should be steroids, then IVIG, and then splenectomy in that order. So again, steroids are number one for this condition of ITP, idiopathic/immune thrombocytic purpura. A splenectomy is performed and platelets return to normal, but then 6 months later they fall again. The answer should be accessory spleen. Sounds weird, but a small percentage of people who have a second spleen the size of a pea that can grow in size if the main spleen is removed. Well, that's interesting. They have a backup spleen. Not everybody can say they have one of those. I don't know. Do I have one? I'm not sure. That'd be kind of a cool thing, I guess you could say. Maybe not beneficial. I'm not quite sure. because it only pops up, I guess, if you have this issue or something like it. I guess you wouldn't even know, right? Maybe you have three spleens. Who knows? All right. Anyway, so von Willebrand disease, autosomal dominant, von Willebrand factor, VWF, normally bridges a glycoprotein 1b on platelets to vascular endothelium / underlying collagen platelet adhesion. Elevated bleeding time, elevated PTT only half the time, no change in PT, normal platelets. Decrease in von Willebrand factor means a decrease in platelet function and hence elevation in BT, but platelet count is unchanged. Von Willebrand factor also has secondary role of stabilizing factors 8 in plasma since we have a decrease in von Willebrand factor. The intrinsic pathway gets messed up, so we get an elevation in PTT, but bear in mind this effect on factors 8 is only a mere secondary role, so PTT isn't always elevated. It's my observation that only about 50% of von Willebrand factor disease vignettes give a elevation in PTT. PT is normal because the extrinsic pathway is fine. 8 out of 10 questions present as a teenager or young adult with a mix of one platelet problem and one clotting factor problem. Platelet problem would be mild cutaneous findings, that is to say, petechiae, bruises, epistaxis, which is like a nosebleed. A clotting factor problem, excessive bleeding with tooth extraction plus menses. Hemarthrosis are clotting factors but are seen in hemophilia, not von Willebrand disease. As I explained, for example, the question can give a 17-year-old girl who has nosebleeds plus heavy periods or a 17-year-old girl who has bruising and history of excessive bleeding with tooth extraction. That is to say, we have one platelet problem plus one clotting factor problem. This is 8 out of 10 questions. I'd say that the 1 out of 10 questions might give only isolated platelet or clotting factor problems, i.e., only say this patient has a history of excessive bleeding with tooth extraction. But they also say that one of the parents has a history of nosebleeds, so you say, oh, okay, von Willebrand disease is autosomal dominant. So that's your combo of platelet problem plus clotting factor problem linked via autosomal dominant inheritance. Okay. Well, 1 out of 10 questions will say the patient has a cut on the finger that takes longer to heal than normal, plus has heavy menses, plus normal platelets, plus has normal PT and PTT, and they don't mention BT. The cut on the finger is their way, by the way, BT is bleeding time. For reference, the PTT is connected to the intrinsic pathway, and then PT is connected to the extrinsic pathway. The cut on the finger is the way of saying the bleeding time is elevated, despite only an isolated elevation in bleeding time here. Since platelets are normal, we know it's not the ITP, and instead is the von Willebrand disease. Ristocetin cofactor and assay is abnormal. All you need to know is that this is some test that is abnormal if platelet adhesion is messed up. The treatment for von Willebrand disease, desmopressin or DDAVP, which can in theory help boost functional von Willebrand levels. You usually don't associate with that. You might think about, when you're talking about that, you're thinking about nephrogenic DI, but you can't actually use desmopressin in theory to help boost your von Willebrand factor release using desmopressin, which is an analog of the natural hormone called vasopressin. Anyway, so I think we're past 30, so yeah, we're 33 right now in some seconds. So I'm going to go take another break and come back to you. Just skip ahead if you find it to be sensible. Okay, I am back. We are on page 155. Let's continue. Hemophilia A and B. Deficiency of factors 8 and factor 9 respectively for A and B. So hemophilia A, factor 8 deficiency, hemophilia A8, and hemophilia 9 is B. So you just think A8, and then you go one letter beyond A, it's B. What's the next letter? What's the next number after 8? 9, right? So that works out, respectively. Both are X-linked recessive disorders, though. Isolated elevation in PTT, bleeding time, and PT are normal. So the elevation in PTT. So PTT is elevated, but the BT and the bleeding time and the PT are normal, though. So there's only this intrinsic pathway that's messed up, which is really not that big of a deal. To be honest with you, I mean, it's not great, but, well, I shouldn't say that, but it's not, it could be a lot worse. I would phrase it like that, because it's just the intrinsic pathway is messed with. The bleeding time itself is normal. Factors 8 and factor 9 are in the intrinsic pathway, so the PTT is elevated, and extrinsic, and that's another way to figure it out, because remember what factors are involved in what pathway. So if you know, for example, PTT is isolated and is elevated in isolation, that means it's an intrinsic pathway issue, which means it can only be so many factors, right? It could be 8, it could be 9, and so forth. If it's only the PT, if only PT is elevated, well, that means it could be, it might be factor 7, right? It might be a factor 7 issue. If both of them are elevated, then it's probably part of the common pathway, maybe like factor 10, maybe, something like that. So just be aware of that. That might help you figure out what's going on. Extrinsic pathway is unaffected, so the PT is normal. Platelets have nothing to do with this condition, which is why the bleeding time is normal. We'll present two ways on USMLE. School-age boy with hemarthrosis who is isolated elevation in PTT. They can also say that he is a maternal uncle who died years ago from minor head trauma. Okay, to be fair, that's not it's not a fun thing to have as an elevated risk factor, dying of things that really shouldn't normally kill you. Neonate who has extensive bleeding with circumcision. Hemophilia A is treated with DDAVP and factor 8 replacement. Hemophilia B, remember that's factor 9, is treated with a factor 9 replacement. DDAVP does not work, apparently, if the question tells you the patient... So DDAVP does not work, apparently. Well, because factor 8 is just a different thing. Factor 8 and factor 9, they are different things. What they're going to be influenced by and for release is going to be different depending on what drugs you use, sure. If the question tells you that a patient with hemophilia A has persistently elevated PTT despite factor 8 supplementation, the answer is check for antibodies against factor 8. Yep, good point. Sometimes patients can develop a resistance against exogenous factor replacements. Interesting. Vitamin K deficiency causes an elevation in PTT, and no changes in bleeding time. Vitamin K is a cofactor for gamma-glutamyl carboxylase, which is an enzyme that activates clotting factors 2, 7, 9, and 10, as well as anti-clotting protein C and S. Bleeding time is normal because the platelets are not affected. We'll present two ways on USMLE. One, the neonate who is bleeding from umbilical stump plus or minus retinal hemorrhages. The latter can sound like a shaken baby syndrome, but the bleeding from the umbilical stump is highly buzzy for vitamin K deficiency. 2. Adult who has been on broad-spectrum antibiotics for 6 weeks that is to say, endocarditis, who now requires a lower dose of warfarin. The answer should be depletion of bowel normal flora. Vitamin K is normally synthesized by colonic normal flora. Warfarin inhibits vitamin K function, so if vitamin K is decreased, we don't need as much warfarin. DIC. Disseminated intravascular coagulation. Runaway effect of clotting factor / platelet consumption precipitated by multifarious etiology such as trauma, sepsis, amniotic fluid embolism, and treatment of acute myelogenous leukemia. elevation in bleeding time, elevation in PT, elevation in PTT, elevation in D-dimer, elevation in plasma activity, decrease in fibrinogen, decrease in platelets, and decrease in clotting factors. Fibrinogen decreased because it is converted to fibrin. Plasmin breaks down fibrin, so more fibrin means more plasmin is upregulated in an attempt to dissolve it. D-dimer equals fibrin degradation products. Since more fibrin is being broken down, fibrin degradation products means, or D-dimer means is going to be elevated. Yeah, and this is an important thing too, is that D-dimer is only going to be elevated if you're actually breaking down proper fibrin clots, not the fibrinogen before, because you can have a situation where you're breaking down lots of fibrinogen, and so you have these sorts of like broken down fibrinogen, which you can measure in theory, but D-dimer specifically is something that's only going to occur if you actually had proper fibrin clot formation in the first place. Make sense? Bleeding from the catheter/IV sites is 9 times out of 10 synonymous with DIC. However, on 2CK surge question, dilutional thrombocytopenia secondary to elevation in blood transfusions presents the same. Blood smear shows schistocytes. And you can see the schistocytes right there for DIC. Okay. Elevated blood for DIC, elevated bleeding time, elevated PT, elevated PTT, elevated D-dimer, elevated plasma activity, decreased fibrinogen, decreased platelets, decreased clotting factors. You see schistocytes. Along with DIC, it's hard to mention DIC and not mention HUS, right? Hemolytic uremic syndrome presents as a triad of 1, thrombocytopenia, 2, hemolytic anemia with schistocytes, and 3, renal insufficiency with or without hematuria. The combination of thrombocytopenia plus schistocytosis equals microangiopathic hemolytic anemia, or MAHA. Mechanism is E. coli, EHEC O157H7, and Shigella both secrete toxins, Shiga-like toxin and Shiga toxin respectively, that cause inflammation and damage of renal microvasculature. Platelets adhere to plug damaged endothelium. The platelets aggregations protrude into vascular lumen, causing shearing of RBCs flying past, leading to fragmentation of RBCs, schistocytes, aka helmet cells. What about TTP? We're just knocking out all the classics right now. Apparently, all the very well-to-go, well-to-do, go-to kinds of things. Oh, TTP. Oh, HUS. Oh, DIC. So forth. Sickle cells after that. So TTP. Thrombotic thrombocytopenic purpura presents as HUS triad plus fever and neurologic signs. In other words, presents as pentad of 1, thrombocytopenia, 2, schistocytes, and 3, renal insufficiency, 4, fever, and 5, neurologic signs. TTP is caused by antibodies against or a mutation in a protein called Adams TS13, which is a metalloproteinase that breaks down von Willebrand factor multimers, leading to unable to break down platelet aggregates that plug renal microvasculature, leading to platelet aggregations protrude into vascular lumen, causing a shearing of RBCs flying past, leading to fragmentation of RBCs, schistocytes, aka helmet cells. Can present as a stroke-like presentation in young women, where they just want schistocytes as the answer. Step 1, NBME. 2CK NBME has plasmapheresis as the treatment. Sickle cell. So here's some sickle cells right there. Autosomal recessive, glutamic acid goes to valine missense mutation on the beta chain. Carrier status, 1 mutation, is referred to as a sickle cell trait, which is less severe than sickle cell anemia, 2 mutations. NBME question wants heterozygote advantage as the basis for existence of sickle cell, that is to say, confers resistance to malaria. Sickle cell crisis can present as an abdominal or chest pain, as well as dactylitis, inflammation of the fingers. The abdominal pain, in particular, as the initial presentation for sickle crisis, has become high yield on NBME exams. A new TCK form gives you right lower quadrant pain plus low hemoglobin in child from Libya. Libya, okay. That's very specific. Where the blood smear is the answer for what will confirm the diagnosis. Okay. The question is tricky because it sounds almost like appendicitis. Diagnosed with blood smear followed by hemoglobin electrophoresis to detect the hemoglobin S. offline NBME question asks, which of the following best describes the molecular basis for sickling in a patient? The answer should be gain of stabilizing hydrophobic interactions in the deoxygenated form of hemoglobin S. This is because the valine is more hydrophobic than glutamic acid, so we have a hydrophobic interactions enabling sickling. Another NBME has an beta chain slips into the complementary hydrophobic pocket on the alpha chain as answer for sickling. Sickling notably occurs with dehydration plus increased acidity. This makes sense since the surrounding environment would become less lipophilic, meaning that the hemoglobin S would consolidate/collapse unto itself to minimize surrounding surface area contact. Hydroxyurea elevates the HbF and can decrease recurrence of sickle cell crises. Sounds weird, but the mere presence of more HbF simply means that there's fractionally less HbS floating around. Okay. Fair enough, right? I wonder how long this section goes. Yeah, we'll do it. We'll go for it. Myelofibrosis, usually a JAK2 mutation, same as the polycythemia vera. The answer on USMLE if they say teardrop-shaped RBCs or dry tap on bone marrow aspiration. A massive splenomegaly seen in 100% of questions. I've seen on NBME also write teardrop-shaped poikilocytes, fancy word that means abnormal RBC, seen as greater than 10% on a smear. In myelofibrosis, the proliferation of abnormal cells in the bone marrow, notably megakaryocytes and granulocytes, leads to the release of growth factors and cytokines that stimulate the deposition of collagen, resulting in bone marrow fibrosis. Essential thrombocytosis, aka essential thrombocythemia, usually a JAK2 mutation, same as myelofibrosis and polycythemia vera, causing proliferation of platelets. USMLE question will tell you a patient who has pain in fingertips, Raynaud phenomenon, or headache, hyperviscosity symptoms, plus platelet count, that is to say 1.4 million microliters. Normal range would be 150,000 to 450,000 microliters. The essential thrombocytosis is a myeloproliferative neoplasm where the platelets can be greater than 1 million microliters. The patient will present with no specific triggering event. Compare this to reactive thrombocytosis below. The treatment would be aspirin plus platelet pheresis, removing platelets from the blood. Reactive thrombocytosis, aka reactive thrombocytopenia. Reactive thrombocythemia. Triggering event, that is to say inflammation, infection, surgery, can stimulate the thrombopoietin production, increased synthesis and release of platelets. It is my observation that the USMLE loves to give reactive thrombocytosis in the setting of an infective endocarditis, where they'll tell you platelet count is 900,000, and the student is like, what the flip? Are the platelets 900,000? It's just the reactive thrombocytosis. The essential thrombocytosis is usually women in the greater than 50 and is symptomatic, while reactive thrombocytosis is anyone and is usually asymptomatic. When reactive thrombocytosis occurs, it will be super high platelet count you incidentally notice as part of the STEM, but the focus of questions isn't the patient's symptoms related to the elevated platelets. For example, there is a difficult offline NBME question where they give a neutrophilic shift with platelets for 1.4 million, where it looks like it could be reactive thrombocytosis due to infection. That is to say, neutrophilic shift usually indicates bacterial infection, but the answer is essential thrombocytosis on this form, not reactive thrombocytosis, presumably because the platelet count is greater than 1 million, rare in reactive thrombocytosis to be this high. And the patient has symptoms, pain in fingertips. Now the treatment would be addressing the underlying infection plus give aspirin. I haven't seen RT as an actual correct answer on NBME form. I've only seen it as baked into questions as an incidental finding where the labs show the high platelets in the setting of infection, and you just, as a student, need to know not to be thrown off by that or think it's weird. Just say, oh, that's probably RT because we have infection/sepsis here. Glanzmann, aka Glanzmann thrombostenia. I've seen this on NBME as just thrombostenia. deficiency of glycoproteins 2b/3a on platelets, defective platelet aggregation. Bernard-Soulier syndrome, deficiency of glycoprotein 1b on platelets leading to a defective platelet adhesion, same as with von Willebrand disease, has abnormal ristocetin cofactor assay. Lupus, systemic lupus erythematosus, classically women 20s or 40s. Most common presenting feature is arthritis greater than 90%. Malar rash too easy for most questions, although you should know that this is a type 3 hypersensitivity reaction. Thrombocytopenia is a mega high yield for step, that is to say, 32-year-old woman with arthritis plus low platelets is lupus. Again, a 32-year-old woman with arthritis and low platelets, think about lupus. RBCs and white blood cells can be decreased, but it's the decrease in platelets that is the highest yield. The cell lines are down due to antibodies. In other words, if you get a patient with lupus where the cell lines are down, this is due to the increased peripheral destruction, not deficient bone marrow production. They're being destroyed. Discoid lupus equals skin lesions. Mucositis means mouth ulcers. So mucositis, think mouth ulcers. When you see discoid lupus, think skin lesions. Elevated risk for malignancy, non-Hodgkin lymphoma, i.e. 44-year-old woman with lupus has seizure plus ring-enhancing lesion seen on CT of head. The answer should be primary CNS lymphoma. Toxa would be the wrong answer in this case. Causes diffuse proliferative glomerulonephritis, as discussed in high-yield renal PDF. Lupus in pregnant women can cause congenital heart block in neonates. That's pretty awful. Sounds weird, but shows up on NBME somewhere. Treated standard flares with steroids, prednisone, for example. PNH, or paroxysmal nocturnal hemoglobinuria, red urine in patient waking up in the morning. Mechanism is increased complement-mediated hemolysis caused by deficiency of CD55 and CD59, plus deficiency of GPI anchor, which protects RBCs from complement-mediated breakdown. Hageman factor deficiency, Hageman factor, or factor 12, the first clotting factor in the intrinsic pathway. All you need to know is that there is such a thing as Hageman factor deficiency that presents as a completely asymptomatic healthy adult who incidentally is discovered to have a significant elevation in PTT. If the factor 12 is low, then the 12A will also be low, which means that less prekallikrein is converted to kallikrein. There is one retired NBME question on where the answer is deficiency of kallikrein in the setting of an asymptomatic 60-year-old dude who has a mega significant elevation of PTT and Hageman factor deficiency. You can call it dumb all you want. We're in agreement here. It does not change the fact that it's on the NBME, which is what you're trying to study for in the first place. Take it up with them basically. Students have probably encountered the question not even realizing this is the way they saw what they saw. Hence, first time you're hearing about this. Anyway, so we are at just under an hour right now. We're at 59 minutes and some seconds. I honestly do want to call it quits at this point. I'm not going to go into thrombotic disorders quite yet. You could say, well, why are you cutting it short? I'm kind of tired, to be honest with you. I'm just kind of want to work on this not now. This is the best way. I want to say that I don't want to work on it tomorrow. It's just that I don't want to work on it right now. That's the best way I could probably phrase it for you right now. Yeah, that's about it. So hopefully this was of good use to you. Regardless, have a great rest of your evening, night, afternoon, morning, whatever it might be for you. Thank you and goodbye. Oh, and one more thing. I want to say that obviously there's going to be a part 2 and maybe a part 3. So look out for that if that's something that you're interested in looking into.